donor doesn't have any post-operative problems. Minor problems is like they can complain of. When you are suppressing immunity, it means you are allowing the infection to grow. So ideally, we keep the patients on. Same thing happens when a kidney is transplanted, right? When a non-functioning kidney is removed and a functioning kidney is transplanted,
Dr. Webha Saudi. So, welcome back.
Thank
First
you.
of all,
Thank you.
post operation, after the patient has undergone a liver transplant, what is his journey after that for the donor and for the recipient?
So first I'll talk about the donor. Okay. So for donors, we just keep he's like a normal individual. There is nothing special you need to be worried about the donor. When the patient when the donor surgery is done, we extubate the donor on the table and shift the donor to the ICU. In the ICU, we keep the donor for 3 to 4 days. We assess the drains, what is the color of the drain, and we assess the liver function tests and what is his bilirubin and what are his enzymes.
How much of the liver is taken, doctor, for the donor?
Yeah, so it is all based on the body weight. So suppose like if I say a guy who is 80 kgs, so for a 80 kg guy as a recipient, you need to give at least 0.8 of his body weight. Okay, so 8 ka 0.8 आप कर लो, so it is 640 grams. So he should get around 640 grams of a healthy liver to have a normal functioning. But there have been incidences and instances where the recipient condition is getting bad, and this we have accepted a GRWR of say 0.6 or 0.65, and they have also done well. So it all depends on how we plan and what is the surgical technique, and there are so many conditions which apply. But 0.65 is also considered as a safe GRWR for a recipient. So when it comes to the donor, so we usually consider 35 to 40% of the remnant in the donor to be safe. Say suppose if the liver weight of the donor is 1 kg, so if we keep around 400 grams of liver to the donor is safe.
But which part of the liver, like the ducts will be attached to certain parts of the liver, no? Which part of the liver will you take? Like,
So usually when it comes to adult transplant, so the right half of the liver is taken and given to the recipient, and left half of the liver is always kept with the donor. Okay, so as you asked, yeah, there are some surgical, and vascular things which happen when it is living donor liver transplant. Like they have to cut the duct, they have to cut the artery, they have to cut the vein, and again do the reanastomosis. But now the techniques and surgical techniques are so precise and very well defined that to have a major complication in the living donor associated with the vascular, be it a bile duct, it is manageable. So it should not be a problem. But coming to the donor doesn't have any problem. Okay, when everything is done, we just properly suture it back and ligate it. Okay, so donor doesn't have any post-operative problems. Minor problems is like they can complain of pain in the post-operative period because their receptors are different from a recipient usually don't have that much pain as compared to the donor. So what we do in the intraoperative period is we give them an option of something called as thoracic epidural analgesia, where the epidural is placed, and in the post-operative period it really helps in getting a better pain control and doing early ambulation and doing deep breathing exercises. So yeah, thoracic epidural really works well, and on fourth or fifth day we just do a set of labs and then shift the donor to the ward.
and for the recipient?
Yeah, so actually for the recipient, surgery is done. Now first day we do the tests on arrival into the ICU. Second day we see how his kidney is functioning, how his liver is functioning, and now on first post-operative day or second post-operative day, we have put a new liver into the recipient, which is not his own self liver. So this liver will be identified as a foreign entity into his own body by his own body cells. So all the body cells will target the graft, which is the given from the donor. So it is being attacked by all the immune cells. So we have to stop this, immune attack. So we have to start the immunosuppressions. So there have been advancements in the immunosuppressions also. Now we, in the immediate post-operative period, we start with triple therapy immune suppression. In the intraoperative period, we give steroids based on the body weight, which helps in reducing the SIRS response in the intraoperative period and in the immediate post-operative period, and also helps in reducing the ischemia reperfusion injury. This is a term, medical term, which I don't want to go deeper into it. So when we start the immunosuppression, we have to make sure that the patient's kidneys are functioning normally, because whatever the immunosuppressions we start, it has an impact on the functioning of the kidneys. The kidneys get affected, they have a renal toxic effect. So we have to be careful when we start this. But generally what we do is we start with a very low dose of immunosuppression in the second post-operative day, say 0.5 grams or 0.25 grams, and we assess how the patient's urine output is, how the drain output is, and say like first 3-4 days the liver enzymes will go up, and then they will reach a plateau, and then they will start coming down. So that is normal with all the recipients. But if the liver enzymes are not coming down, so you should be thinking why it is not coming down, whether the graft is functioning properly, or is there any cause for why this liver enzymes are going up, is there any sepsis, source of sepsis, or it is purely rejection. So these are the two things which can happen in the immediate post-operative period. So rejection can also happen on table, which is called as primary non-functioning of the graft.
During the surgery?
Yes, during the surgery. So generally when the surgery is done, when the vascular anastomosis is done, when we connect the portal vein of the recipient to the portal vein of the donor, so the flow in the liver is established. Okay. Once the flow in the liver is established, it starts producing bile, which is a good sign. Okay. When the flow is established into the liver tissue, which was kept in the ice water, generally when we take from the donor, we put it in a cold ice pack. Okay. So that is called as cold ischemic time. So to have a good graft function, you should have a minimum cold ischemia time and a minimum warm ischemia time. Okay. So ideally, if you say something less than 4 hours of cold ischemia time and something less than 30 minutes or 40 minutes of warm ischemia time. So that gives a good graft function. So when this portal vein anastomosis is done, when the hepatic artery anastomosis is done, so you see the change in color of the liver, which was pale white or not pink. It suddenly becomes pink. That means the flow in the liver is good. The liver starts producing bile. That means liver is started functioning. Same thing happens when a kidney is transplanted, right? When a non-functioning kidney is removed and a functioning kidney is transplanted, he starts making urine. Same thing happens with the liver. But there are other functions of the liver, like synthetic functions like coagulation factor synthesis, protein synthesis. All these things will not start happening immediately. So what you have to see is the change in the color of the graft, the bile synthesis, and the production of the bile, and the temperature. The patient's temperature starts rising, and sugar levels. So sugar levels starts picking up. Generally all chronic liver disease patients, sugars are on the lower side, because liver has a function of making sugar also. So now because this new liver is functioning, sugars level starts picking. So this we see in the intraoperative period, and this we also see post-operative period, the sugar levels, the lactates. Lactate is nothing but how your body metabolism is happening, and nothing is allowed to settle as acids. Lactate is nothing but acid. So acids are not good for body. So when the new liver starts functioning, it takes care of the lactates. So lactate is not synthesized. When anaerobic metabolism is happening, the lactate levels goes up. When aerobic metabolism is happening, lactates don't increase. So then when we start then coming to the immunosuppression. So in the immediate post-operative period, we started from the second post-operative day, and we assess the tacrolimus level. Immunosuppression is nothing but tacrolimus. Okay. So we assess the tacrolimus levels after giving every fourth or fifth dose, and in the initial period, what is to be achieved is around 7 to 8 nanograms, which is the set target for tacrolimus. In some patients, you can go up on the higher side, like in autoimmune disease or in doing retransplant. Like some patients can need a double, two times a transplant, like the earlier liver is not functioning, so they can take a second transplant. So in those patients, you need to have a higher immunosuppression levels. So first 15 days or first week, we target tacrolimus trough levels of 8 to 10 nanograms, and then we slowly come down to 5 to 7 nanograms. So that means that we are achieving adequate immunosuppression for the graft to function normally. And another thing what we should take care is, it should not have flare up of infection. When you are suppressing immunity, it means you are allowing the infection to grow. Okay, so ideally we keep the patients on antibiotics for a period of 1 week. We also keep the patients on antifungals for 14 days in the post-operative period, and then we also assess the markers for sepsis, which is procalcitonin and some other tests which we need to do. And after achieving proper trough levels of the tacrolimus, we also start something which is called as a CellCept. It's a second immunosuppression, and the patient is already on steroids, which is continued based on the body weight. For the first 5 days, we give IV injection, and then slowly we start them on tablet of steroids. So some patients need double immunosuppression lifelong. Some patients need only single immunosuppression lifelong.
So, does the body ever accept the foreign liver? Is there a point where the body actually accepts the donor liver
Uh,
in the
See,
recipient's
body,
life?
yeah. So the most important phase is the first month post transplant, where the liver chances of getting rejection are very high. Although it can get rejected anytime, even after the transplant, but the chances of getting very high, chances of getting rejections are very high in the first month post transplant, because you are more prone for infections because of higher immunosuppression. So sepsis related rejection can happen. Sepsis related stasis can happen in the body, which increases your bilirubin levels and affects the newly implanted graft. So then after first month, in first month also the patient is prone for a lot of bacterial infections, so that also contributes to kind of sepsis related rejection. So after first month, from say second month to 6 months, there is a different set of organism which is responsible for having infections. So your viral infections can lead to sepsis and cause rejection. So we screen the patients for cytomegalovirus and Epstein-Barr virus, and also other viral diseases like hepatitis, HIV, and herpes. So all these viruses, they can get activated in the immediate post-operative period. So there are tests which we do to identify if there is any recurrence or surge of these patients.
Doctor, is a woman's liver different from a man's liver in the sense that is it that a man's liver gets affected faster than a woman's, or post surgery a woman's liver recovers faster? I mean, is there a distinguishing factor or?
No, no, it doesn't. It doesn't work like that, because everybody's response is different, and you can say the chances of liver disease in men are more because the risk factors or whatever the habits they have. Yeah, so they are more prone for having liver disease, but in some race and some ethnicity you will find that difference. No, females getting affected more than male, but I don't agree to this remark.
And what are the advancements that you have observed, in the last, say, a decade in the area of liver transplant?
Yeah, so the liver transplant in our country and in state of Tamil Nadu, it's become more organized. There are organizations like Transtan, and there are also other organizations which work hand in hand with Transtan, and even the hospitals where the transplants are being done are better equipped and have all the specialists working hand in hand in coordination as a team for getting the transplant done smoothly. And also there are advancements like transplants being done laparoscopically, transplants being done by robots. So in India there are centers where donor liver resection is done in lab. So I think in Kochi they are also even doing in a robotic liver resection. So the advantages is that it is more less pain inducing, like pain free and more precise when you go with a robo. So vascular things are more accessible. So that comes more a surgical topic. Surgeons can talk more better about it, but it has its own advantages and also it has its disadvantages because it takes a lot of time and it is just started to pick up. But definitely over a period of time, technology definitely is going to help in liver
And what
transplant.
about your practice at MIOT? Like, how have you seen the development of it, or how are you in the fray of the modern advancements at MIOT?
Yeah, so MIOT hospitals is very well equipped with all the necessary needed things, whatever is needed for a transplant, like a well equipped ICU, good post operative care, good nursing care, learned nurses, nursing staff, and we have all the specialists to do the required assessment in the pre-operative period. We have a very cooperative managing director who.
And the areas of laparoscopy and robotics, are you also
Yes,
very
so we have recently got the most advanced Robo Da Vinci system. Uh, we are planning to start with the robotic liver resections first.
so robotics is for every area of transplant?
Robotics can be used for no, yeah, it can be used in transplant, it can be used in other surgeries. The most important use of robotics is for the abdominal surgeries, lower abdominal surgeries like prostate, CA, or ovarian cancer, and it can also be used in orthopedic surgeries. So we are doing it for surgical onco cases now in MIOT, and also we are planning to slowly implement it for liver resections. Then we may probably implement in the donor surgeries.
That's amazing. I mean, robotics, usually on BBC or on any channel you see, it's happening in the US and the UK, and it's great that MIOT is facilitating all of these advanced medical treatments and
Yeah,
interventions.
yeah. I would like to thank our MD, Mr. Prithvi Mohandas, for this initiative. He's very, very supportive, and he's actually, he doesn't want to miss anything which is innovative and new. So, in any field, whether it be transplant or other surgeries, is always for the MIOT brand MIOT.
Thank you, doctor. It was such a nice conversation with you. And I mean, I certainly learned a lot in the last three episodes. And I think I'm sure the viewers will be very, very interested and they'll learn a lot too. Thank you so much for your time.
Thank you for this opportunity. I hope I have done justice for whatever you have expected from
Definitely,
me.
I think people will be very interested. And it was very informative. Thank you.
Thank you so much. Thank you.